on CMEs and CEUs. If you guys have any questions about these, Rana's the person to get ask those questions of. I do not have anything to disclose or related to the content of this, this activity. Today, we're going to talk about cognitive behavioral therapy in a nutshell, and I'm going to go over some relapse prevention strategies. So the first half is going to be kind of a really quick and dirty overview of what cognitive behavioral therapy is. I know some of you are therapists on this call, so this is not going to be any new information. For other individuals who may not have had formal training in CBT, but you kind of hear that thrown around, or maybe you've had some workshop training, hopefully this can tie some things together for you. And then the second half of the lecture, I just want to introduce you briefly to some of our sort of core techniques that fall under the relapse prevention umbrella, which is a CBT model. So I just want to, this isn't going to be sufficient to actually apply these necessarily, but you will get the slides, and if you want the actual worksheets, you can reach out and I'm happy to share them with you. But just to give you a kind of a idea of how you could use some CBT components in your brief intervention work with people. And so as you're going through and I'm introducing these, if you're like, ooh, that would be helpful, the way CBT is built, it's really nice. You could pull it out and just use that particular piece. So Rana, will you monitor the chat and let me know if any questions come up, and I'll stop.
Will do. Thank you.
So I want to ground this in the stages of change. Hopefully most of you are familiar with this. If not, stick around and we'll cycle back to a lecture where I go over in more detail the stages of change. But this is a model that explains how people move through changing their behaviors, and where CBT tends to fit really nicely for individuals is in the action and maintenance. So when we're talking about applying CBT skills, particularly relapse prevention, it's going to fall in those two stages. We're not necessarily going to be using some of the strategies we're going to talk about today in the earlier stages, because people aren't really in a place where they're ready to clearly start to make change with their use behavior. So in those areas, we're going to use a lot more motivational interviewing, motivational enhancement strategies. But relapse prevention is really, really helpful, and CBT for any use disorders, really, really helpful starting in the action phase. And then once people are gaining some momentum and changing their behavior, then really hitting it when they move into maintenance. This is another model that kind of steps you through where patients could be and where things fit in. So when people are new to recovery, they're just starting to identify what their recovery motives are. They may be pre-contemplative, may not even really want to move forward with making some changes. Harm reduction would be the preferred intervention. Then once there's any ambivalence, we can apply our motivational interviewing strategies. And when they move into, okay, I'm ready to actually do something, that's where identifying triggers, warning signs, looking at the different domains of what fall into well-being and overall recovery, and applying clear CBT is super, super helpful. So I hope that kind of clarifies where these pieces fit into the patient's trajectory. We don't want to treat all patients with the same thing because they may be coming to recovery with different needs at different points in time. So talking specifically about cognitive behavioral therapy, what is it? Well, it's a talk therapy that really focuses on helping patients understand and apply that knowledge of the links between their thoughts, their feelings, and their behaviors. So the things that they say to themselves, the emotions that are evoked by the things that they say to themselves, and then the behaviors that they engage in as a result of those emotions. So helping people understand those links and actually begin to intervene on them is really the crux of any CBT work. It has tremendously good evidence for treating addiction. Other theoretical models have been shown to be helpful, but the nice thing about CBT is you can apply it to a fairly large audience, and it's pretty straightforward, pragmatic, skills-driven, And it really empowers patients, because if it's done correctly, then you're giving them the knowledge and the tools to be able to apply it to their own life. So it's not something that once they've learned that skill, they don't need the therapist anymore. They don't need the provider anymore. They can continue to apply it as different things show up in their life. That has been shown on numerous controlled trials on multiple substances, so marijuana, alcohol, cocaine, opioids, nicotine, and individuals with a dual diagnosis, so having a comorbid mental health condition as well as a use disorder. And there are a number of CBT protocols that are built for dual populations that can look at, okay, somebody has severe depression and they're also abusing alcohol. How do I treat both at the same time? What's nice about CBT and why I think it's helpful, even if you haven't really thoroughly been trained in this, you don't necessarily need to do a full CBT protocol. If your relationship is med management, or your relationship is case management, or whatever role you're playing with the patient, you can still apply some of these techniques and it'll be helpful, right? So it's highly flexible. You can implement it across settings and across providers. It's intended to be very short-term and focused, and it works in combination with medication as well as other therapy modalities. So a lot of other protocols may have some flexibility, and you can add in, especially if individuals have even some lower level substance use stuff. They might not even meet criteria for full substance use disorder. You could apply some of the techniques that fall under the relapse prevention umbrella to help them kind of get that use under better control and prevent it from becoming a full-blown problem. So you can integrate it into other therapeutic modalities that you may already be using. This is a visual of the CBT Triad. It includes the physiological component, which I think is important, but what we're teaching patients and what we're using with most CBT materials is this relationship between something happens in the environment, a triggering event occurs. So I go to the gas station to pay for my gas, and I see the liquor bottles behind the counter, and then that triggers a urge to want to go and use. So that's an environmental trigger that cues up this cycle that's in the center. And so typically people will have a thought before anything else. They may not always be aware of that thought without some practice, but typically the cycle sort of gets kicked off with what's called a cognition. So that's a thought that triggers this cycle. And typically those thoughts are distorted and inaccurate, which means that they are not a factual statement. They're something that's typically unhelpful or extreme. And what that does is trigger the cascade of an emotion. So there's an emotion that's tied directly to that extreme or unhelpful thought. Their body then responds to that emotion, because most of our emotions have a correlated physiological sensation, right? So just like when we experience fear, we tend to have rapid heartbeat and increase respiration, and various other things occur that make the experience of anxiety, right? It's the combination of the emotion plus the physiology. And then that will elicit a behavioral response. Typically, especially for individuals with a substance use disorder, it's about avoiding that painful emotion and or thought. So the behavior is in the service of breaking out of the cycle, but unfortunately, it tends to be not that helpful unless they've learned a more helpful way of coping with those painful thoughts and emotions. So this is the CBT Triad that we teach patients, and most of the techniques are geared to help them begin to unravel this and make connections between them so they can intervene. Because where humans can make change is with changing their thinking or changing their doing, right? And so what we're teaching patients to do is be really clear about those two areas of the cycle. Because the emotion and the physiology is linked to the extreme thought, it's really, really hard to change that. They might be able to do it temporarily, which is what drugs are really good at doing, right? They can stop, slow down, change the emotion, but only temporarily. What we're teaching them is a really powerful technique to be able to truly enact change, which is to identify what's causing the cycle in the first place. That is managing those external environmental triggers effectively. And then when the unhelpful thought shows up or they engage in an unhelpful behavior, to intervene at that level. And then it changes the entire cycle. So that's really what we're trying to accomplish with most of the CBT techniques. In general, if you're going to conduct a full CBT session, or even if you're going to just be applying one of the techniques I'm going to talk to you about today, you still want to follow some guidelines. So in general, when doing even a brief technique or a full session, these are best when they are set up to be structured. So the clinicians are not passive. They take a very active and involved stance with educating about the intervention that's going to be conducted, giving the rationale as to why it will be helpful, practicing it with them, and then sending them home with an assignment to practice on their own. A traditional CBT session is typically 60 minutes, so about an hour, and it's divided into sub-sessions. So if you think about, okay, I only have 30 minutes with a patient, I want to go over this technique, you still can apply this same 3 sub-sessions. Just think about the time that you have allotted. So if you have an hour, you can break that into 3 20-minute sessions. If you only have 30 minutes, then you need to break that into smaller intervals. But keep in mind that it will be more beneficial if you can subdivide it the way I'm going to show you here in a minute. It's really important when doing this that you're actively balancing teaching and coaching with acceptance of where the patient is at. Because if we're just full on teacher mode, we might miss, are they really getting it? Or is this really going to be helpful for them? Are they bought into the rationale? So it still requires some good clinical skill to be able to balance, like, am I accepting them for where they are and what they need in this moment? And also teaching and coaching and providing them a really clear skill that could be helpful, right? So managing, not being overly directive or overly passive. So kind of finding that sweet spot in between, like we do with most of our helpful interventions. So now I'm going to show you the 3 subdivisions and how you can break it up and why. So the first 20 minutes of an hour-long session, or the first sub component that you're going to cover when you're doing a CBT intervention, is you need to set an agenda. So every CBT technique or session starts with explaining, this is what we're going to do today. It should be really, really brief. And it should be, if possible, connected to what the client or the patient's current concerns are. So not talking about stuff that happened a long time ago, but what you've come to know is important to them right now, today, so that they can make that connection. What I need, what's important to me, is connected to what we're going to talk about today. So if you're doing good CBT, you never really start a session with, how was your week, or how have you been? You don't ask those kinds of open-ended things, because your goal is to complete a task. And for anybody who has had really good teachers or has been trained in any kind of pedagogy, you'll learn it's the same technique, right? That we have to, we set the lesson plan right at the beginning, and we create a clear path of how we're going to get through that. And that's really what you're doing in this first sub-session, or the first 20 minutes. Also, if you have that hour and you're doing traditional CBT, you're going to want to collect any logging information that you assigned from the previous session, and that could be about use and or cravings and urges. And you're going to want to review that, because if you assigned it, you need to look at it. And the same thing with any practice exercises or homework. That's really, really important that you do that at the very beginning, so that way you don't get to the end and say, oh yeah, I forgot to check on your homework. Well, then it becomes less important when you do that. So that's the first thing that we do, is we cover anything that was assigned or that you asked for them to collect to bring to you from a previous session. If it's the very first time you've met them, of course you would leave that part out. The middle section of a CBT session, This is where you're going to introduce the technique or the new skill that you're going to teach. So what was that that agenda that you're going to be covering? This is what we're going to cover today. So in this section is when you actually cover it. So it's what it is, and then you need to actually again tie it back into their current concerns. This is how it's going to help them. That's providing the rationale. You want to do that in layman's terms or in the educational level vernacular of the patient that you're working with. So again, it's to empower them to use the technique. So if they don't understand it, they're not going to use it. And then you need to practice it. So that's really important that you leave enough time to introduce it, why it's important, and then we're going to practice it right now together. If it's a worksheet, you just do an example with them. If it's some other technique, you might actually do a role play, right? But you need to leave time so that they get the experience of working with that skill with you before they go home and try to practice it. And then the last part, the last 20 minutes, is about checking for understanding. So this is where you want to explore, did they get the rationale? Did they understand how to apply it? Did they have any questions about the skill that you introduced? You, if possible, collaboratively come up with the practice for the next week, right? This is what you recommend. What are they willing to do? And then you review high-risk situation plans for whatever period of break you're going to have. And I'm going to introduce high-risk situation planning at the end of this lecture. So if you're not familiar with that skill, you'll get to see it. Any relapse prevention work must include doing high-risk prevention planning every single time you see the patient. That's not a one-time thing. That's something that you do week to week. And then if you have, if you're using scheduling or logging, you'll do that part at the end too. So some challenges with CBT that we run into is it can be really hard to stay focused. That's a lot to cover. Even in an hour, that's a lot to cover, even just introducing a single skill set. And if you don't even have a full hour to dedicate, you need to be pretty brief and on target, right? You need to stay focused. And that can be difficult, especially if you have a relationship with a client, they're used to coming in and kind of talking about anything and everything, to shift them into a much more directive and focused approach. The clinician may have to problem solve, particularly around homework. Practice in between sessions is typically the most difficult thing for folks to want to do. And then we run into a lot of challenges trying to convince them why it's important. But if they're not doing the practice work in between sessions, they're really not getting a sufficient dose of these interventions. They're not magic. They're not going to work if they only do it once. They really need to do it regularly until it becomes integrated into their life, and then they'll be able to benefit from the technique. And so staying on point, staying on agenda is really important. And then also making sure that you're not being overly rigid, that you're being flexible enough, that you're still listening, that you're still using all of your good common factors approach. General things to keep in mind, you cannot repeat enough, repeat. Recognize that the habits that folks have developed with a substance use disorder are really deeply ingrained, that these things have been habitual for quite some time, if not many years, and that is their default. And so if you're asking them to do something outside of that, they might need a fair amount of repetition. Every time they meet with you, you might need to go over that skill again. You might need to remind them, you might need to reintroduce it. So don't be afraid to repeat. It's okay to also say, you know, learning takes time, and to replace the old with the new. And so they might need several attempts to take over that one skill or that one practice assignment. The other thing to keep in mind is that individuals with substance use disorders oftentimes have things that have the drugs themselves, the chronic use of those drugs has affected their cognitive abilities, their memories. And so repetition is even more important for this population. Then we add in things like trauma and TBI, and we have an even more complicated cognitive picture. And so making sure that you have multiple tools. So it's in writing, you said it verbally, they've gotten to practice it. So multiple ways for them to learn, and that it's and that they have multiple times of it being exposed to it, because their minds might not be working at the level that some of these protocols are expecting them to be working on. So a basic concept, it's okay to be repeated numerous times, and you might need to repeat parts of a session or a whole session numerous times before they get it. What's important is that they get it. So that's your guidepost. If they're not getting it, you keep doing it. The other thing that's super important and that I think we tend to forget a lot is the why. If you're not giving a clear rationale that's connected to the patient's values and their current needs, they're not going to want to do it. It's not going to be meaningful, and they're not going to care about what you're trying to teach them or show them. So you must constantly be stressing the importance of what you're asking them to do, whether it's in session practice or outside of session practice, that they need to understand the rationale. So I think that's a good thing for us to, anytime we're going to introduce a topic or a skill set, we want to clearly in our mind understand what is the why and how is this going to benefit the patient. The other pieces that fall into CBT is making sure that you are using monitoring tools. So that logging, scheduling component, and then the high risk situation component bookends every CBT intervention. So that monitoring is really part and parcel of any CBT. And then the other thing that's really important is to praise approximations. So what we're doing is trying to change really deeply ingrained habits. And so people aren't going to just change overnight. They're not going to, insight is not sufficient for change. It's necessary, but it's not sufficient. And so them understanding the consequences, them wanting to change is typically not enough. That shaping of their behavior needs to occur, and that takes time. And so anytime you see a helpful or healthy shift, you want to praise that. You want to reinforce the heck out of that, even if it's just showing up again. If they didn't do their homework, that's okay. Hey, did they think about it? Yes. Where did they keep it? Where did they lose it? Let's problem solve that. It's not about, them doing a great job. It's about what did they do that you can praise to start to approximate the overall goal. So overcoming some of these obstacles, primarily the practice one, is one of the biggest jobs that we deal with. So individuals with the types of mental health conditions that come along with a substance use disorder, and substance use disorders themselves have a tremendous amount of avoidance. There's a lot of experiential avoidance that's going on. So why wouldn't they avoid homework or practice outside of session that's geared to help them start to really look at that and change their behaviors? What's important is providing that rationale and praising the approximations when they do anything that's close to it, but also not getting demoralized yourself as a provider, making sure that you have it at the top of that first 20 minutes or that first 5 minutes that you interact with them to talk about the practice that they've done since the last time they saw you, that has to be something you do on rote. And think about the language that you use with them, because they're already coming in feeling typically demoralized or concerned. They want to be a good patient. Most of our patients want to be, quote unquote, a good patient and do what you've asked them to do. And when they haven't, they feel pretty bad about that. So thinking, how can I frame this in a really positive way, right? So just thinking, what did you do that was awesome? How could we make this easier? What got in the way? Let's explore that, so that, because maybe we bit off more than you can handle in 1 week or 1 month or whatever the time limit was. Okay, so that was CBT. Any questions about those pieces before I move into the components?
I think you've got a couple of questions, Dr. Maley, in the chat box. You want to go?
Move pretty quickly through the next sections so that we leave enough time for those two things, and we'll come back to them. So I just want to really quickly introduce you to some of these relapse prevention interventions if you haven't seen them. And then again, if you want further worksheets or information, feel free to reach out to me. So trigger identification is that external box. So that's looking, it could also include internal triggers, but it typically is just identifying what are the things that are like pushing the first domino, that are causing the thoughts and then the subsequent behaviors to emerge. That's triggers. And so identifying those and coming up with a plan to manage them is extremely important, because a lot of things occur between the expression of the trigger, whether it's internal or external, and then the use behavior. There's a lot of things that happen in between where we can provide some skills for patients to intervene on their own behalf to avoid that inevitable use. So what's happened for folks who have a substance use disorder is the same thing that happened with Pavlov's dog. So it's a classical conditioning process, which means it's something that is a unconditioned stimulus partnered with a neutral stimulus. And then over time, that neutral stimulus becomes the almost the same, right? So the drug has happened, both the drug seeking behaviors and the drug use behaviors has happened within an environment that has a tremendous amount of variables or stimuli connected to it. And over time, those variables begin to trigger the same compensatory response as the drug itself. And they're interacting with this thousands of times a day. So trigger identification is really, really important and helpful to helping people prevent relapse. You can do this in a couple different ways. You can use a functional analysis, which is what you're trying to get at the information of drug set or setting to identify what are the triggers. You can tie that to what are the long-term and short-term positive and negative consequences, both of use and non-use. And you can look at a series of what are called positive reinforcements or behavioral contingencies to give them a meaningful alternative to use when they are triggered. This is an example of a functional analysis. This is just a worksheet that you could spend a session doing with a patient that helps them identify the external and internal triggers, and then those positive and negative consequences, which is really helpful for people to kind of start to think through, oh, how is it affecting me in the way I want it to? And how is it affecting me in the way I really don't want it to? You then can link that to what are called behavioral contingencies, which is the connections between the triggers and the urges and then the behavior, and start to shape that for folks so that they're using substitutions instead of just avoiding it, right? So we don't tend to change in a vacuum. If I'm trying to stop a behavior like drug seeking, right? I'm trying to stop going down that street to get the drugs that I'm craving. Well, I have to do something in its place. If I only have the stop, I can only do that for so long. So as human beings, we have to put another contingency there. And people respond to reinforcers really predictably. So multiple studies have been shown that if we can reward a desired behavior, we will see shaping of that behavior. Punishment also works, but it doesn't work as well as rewards. So what we want to teach folks is how to reward themselves, how to put that substitution in place that is truly reinforcing for them. You could also develop a set of reinforcers that could work when they come to see you. So you could even reinforce attendance. You could reinforce homework. You could reinforce a lot of different things. This is an example of an alternatives to use table that you could go over with a patient. So you could say, okay, let's identify what's the triggering situation and the positive consequences of use. And then let's come up with a alternative or a positive reinforcer that could replace the use behavior, and also look at similar positive consequences, because we want it to be as balanced as possible, right? So when we're talking about using heroin and comparing that to going on a walk with your friends, they're really not that comparable. And so it's going to take a while to shape that behavior to get it to the point where going on that walk is truly reinforcing. So we might have to have a lot in the alternatives to use side to counter the single incident of using a drug. So thinking about like it's the intensity and the impact of what you're comparing when you're setting this up. The other thing that you can do that goes hand in hand with trigger identification is urge management. So we said that there's a trigger, and that's directly connected to a thought to use, which is connected to the urge that I'm going to go and engage in the behavior of getting and using the drug. So this is where we want to apply our logging and monitoring. So it can be really good to have some kind of either a use or urge log that you go over with them and you assign for them to do on a regular basis. This can be helpful for them to sort of track how much they actually are using, and then what are the thoughts and feelings connected to it. So what are the sort of the triggering situations that are connected to it. And then you also want to give them some tools for managing when the urge comes up that allows them to avoid the use itself. So this is where you explain that urges are temporary. It's like, um, a wave in the ocean. If you're wrestling with it, you're not going to be that successful, versus if you can just think about it, hey, I just need to surf right over the top. I don't have to do anything and it will pass. That really what it only tends to last about 20 to 30 minutes. It might come back, but then you can write it out again. And every time you write it out, it gets less and less powerful. It gets weaker over time. So we can provide them that education and help them start to identify, label, and make a different choice with that urge when it shows up. And there's a number of other techniques that you can go over to help people with urge surfing. Lastly, I want to go over high-risk situation planning. This is the one that I said should bookend any good CBT intervention. If you do any, I think, harm reduction intervention, this is the one that is extremely helpful, because what this does is helps people think into the future, to have a clear plan of how they're going to manage their craving, their urge, their trigger, so that they can avoid using effectively. So just like how we need to have a emergency fire drills at our work, so we know which exit we need to go to and where we need to stand, all of those things are in place so that when we're in the actual crisis, we know how to behave. We don't even have to think about it. It's just rote, right? We're not allowing the panic or the emotion to overwhelm us because we've practiced it so much. So that's what we're trying to get people into the habit of doing. So firstly, we have to have a conversation with them about high and low risk situations. So help, once you've identified, what are those triggers, then they can clearly identify a high risk situation is one where they're going to be very triggered and most likely to use. And a low risk situation is where they're around people, places, and things that they're likely to not be triggered and very low likelihood of using. So we want them to begin to shift the balance from spending most of their time in high-risk situations to most of their time in low-risk situations. This is a example worksheet that you can use to start to have them think through that. So on a week-to-week basis, or if you only see them every month or every couple of months, you would adjust the timeline, but you want them to think through, what are the situations that are coming up that are truly high risk, that you are likely to be triggered, you are likely to use. And now let's brainstorm how you're going to handle that situation and come up with really concrete, clear plans that they can enact if that situation arises, if they find themselves in that situation. A couple notes here, you want to make sure that you've talked with them about where they're going to keep their high risk situation worksheet so they have it on them. Maybe you have them put it on their phone or they write it out, take a picture of it, but they need to have it on them or it's of no use. It's not good enough for them to do it and then think that they're going to have it in their head when they need it. They need to be able to pull it out and read it and enact it. And so therefore the plans also need to be realistic. So this really is an opportunity to collaborate with them and say, are you actually going to implement that plan? Or is that just what you'd like to be able to do? Like, let's think through what's truly realistic for you in this situation. And that's why this is set up so that you can have numerous plans, right? So you could increase it in terms of difficulty for the patient. So it needs to be either daily or weekly. So if you only see them with like a large gap between, then you want to give them numerous worksheets so that they can create one for that entire span of time between they see you. It's really, really useful for them to also tie this with a schedule. So if you're also going over scheduling, or they have a calendar, or they don't have a calendar and you want to give them a calendar to try to use, but to tie their high risk situations into their weekly schedule. Because for a lot of folks that don't have a scheduled out day or week, that leaves a lot of margin for tough things to happen unexpectedly. And so you can't really plan out what the high risk situations are going to be. So thinking through, like, let's actually nail down, what is your day going to look like? Even if we have to dig into hour by hour, because that's really going to maximize their ability to accurately assess the time that they're going to spend in low risk versus the time they're going to spend in high risk situations. Okay, that is the lecture. So now we can go